This is a beautiful, beautiful hospital. Seattle Children's Hospital is unique in that it serves the 5 northwestern states, and it takes any kid in that region, any child, regardless of their parents' ability to pay. So my name is Rich Ellenbogen. I'm from Seattle, Washington. I work at Seattle Children's Hospital, Harborview Medical Center, and the University of Washington School of Medicine. So what is a Chiari malformation? Well, a Chiari malformation is named after an anatomist named, or a pathologist named Hans Chiari, who was a scientist at the turn of the 20th century who discovered an abnormality in the back of the brain, specifically the cerebellum, and it was described in pathologic terms. In other words, this was described in people that had died and had autopsies. We now, of course, make the diagnosis while people are alive with MRI. And what specifically it is cerebellar herniation or cerebellar tonsils that go below their normal level through the hole in the bottom of the skull, 5 millimeters or more. And they have symptoms of classic headaches, Chiari headaches, the ones that are worse with straining or coughing or laughing, bending over. And they're almost always in the back of the head. Now, Syringomyelia is fluid that's trapped in the spinal cord. Syrinx was the goddess of water. And when Pan placed his arms around Syrinx, she turned into a bundle of reeds. It is very important in the workup for this problem that you get an MRI of the head and the spinal cord, because you can have this cavitation in your spinal cord. So over 80% of the time, by treating the Chiari malformation, by decompressing the back of the brain, the syrinx collapses significantly. It doesn't go away. You always have some remnant, but it does have a sustainable treatment. Syringomyelia often occurs from trauma. So patients that are in bad traumatic accidents, or patients that maybe have had issues in the past that they don't even remember having the trauma, can have a traumatic syrinx without the Chiari malformation. And those patients undergo an entirely different workup and an entirely different treatment for their syrinx. Many of those patients can be watched or at least investigated for the cause of their syrinx. Others need an operation to decompress their spinal cords or drain their syrinxes. But it's important to note that many times you can treat the syrinx from Chiari malformation by first treating the Chiari malformation. But once again, you have to look for the associated problems with Chiari malformation, like hydrocephalus, like problems at the cranial vertebral junction, or rarely, and only rarely, a tethered cord. In my practice, do I see associated with those 2 or 3 things. So this is a child that was self-referred. In other words, mom and dad, who were pretty sophisticated people, did not take no for an answer. This is a child that kept aspirating, which means that every time that he ate, some of the food or some of the liquid would end up in his lungs, giving him a pneumonia.
He drooled a lot, and he was very gurgly like he is now, and he had troubles eating and swallowing.
Because his brainstem's being crushed by this.
He's delayed in fine motor, and all of that To make a very long story short, all of that kept getting worse and no one knew why. And I kept going to the ENT, and I think they finally got sick of me bugging them. So they said, okay, in June they said, just let's do an MRI.
And sure enough, he had this amazing Chiari malformation, in the sense that it was a fairly extensive Chiari malformation that explained, by the way, he had neck pain, which were his way of saying headaches at age 4. And that he had fine motor problems because he had Syringomyelia. So you're going to be with him in the morning, and I'll come talk to you again.
Yeah.
Okay, I'm going to bore you again.
That's okay. No, you're not boring me at all.
You ask any last minute questions? We bring him into the back. We're going to make an incision right there.
1.5 inches?
Yeah, about 2 inches. And then we make another incision here, because that's where we get the graft from. These are patients who have, a lot of times, what I tell them, a size 10 brain and a size 9 skull. And so our goal is to cut away a piece of the skull and the first cervical vertebrae to give their brain more room. And we open up the covering of the brain called the dura mater. We bring in a microscope and we spread the muscles. We don't necessarily cut the muscles, but spread them apart so that we can see into the back of the skull.
So what we're looking at now is the microscope view from the incision that we made in the dura. So what Dr. Ellenbogen is doing right now is using bipolar cautery to cauterize back on these tonsils. And you can see as he uses this electricity, the tonsils are shrinking back. And you can see that they're very carefully and systematically working from one side to the other to provide additional exposure and gradual retraction of those cerebellar tonsils.
Then we sew in a patch. Now I take the patch from the patient, from the covering of the skull called the pericranium. I make a small incision above the area I've been operating and take a nice piece of the patient's own material. And for me, that seems to work the best because the patient doesn't reject it. They recognize it as their own material. And then I put in sutures until this patch or quilt that's shaped like a triangle fills out like a sail. And what it's filling out with is the cerebral spinal fluid that's now circulating and percolating around the cerebellar tonsils that had obstructed the flow of that fluid before. The operation has gone perfectly in terms of the technical aspects of this operation, but that's only one little parameter. The real measure of how the operation goes is how the patient is doing. Tomorrow I'm going to examine the patient, make sure he's neurologically normal, make sure that he is intellectually and cognitively at his baseline, and then I want to see him walking, talking, and interacting. That'll be the short term. Long term, in about 3 months, I'll get another MRI of the head and spine, looking for a change in the configuration of the cerebellar tonsils, flow of the spinal fluid around the cerebellar tonsils, brainstem, and spinal cord, and collapse of the syrinx. That's what I'm looking for. We see failures. I don't think we're seeing more failures than before. Part of my practice specializes in taking care of people that have had failed procedures. But the reality is that's only a small percentage of all the operations we do. I think failures occur for a variety of reasons. One is sometimes the patient should never have any surgery. They really didn't have a Chiari in the first place. or their Chiari was mild, or too much surgery is done. We have patients that get the wrong operation or too little surgery. And of course, the third reason is, as we discussed, there are patients that have associated problems that are not recognized. If a patient has a headache once a month, we might say, well, I'm not sure the risks are worth the benefits for this surgery. Now, a patient like the one I operated on today had terrible problems, and the benefits far outweighed the risks by orders of magnitude of 10. Because if we didn't do the surgery, he would keep getting worse, and actually, there was a risk to his life. I tell every family about second opinions. In fact, whether it's a brain tumor that a patient with a brain tumor or it's a patient with a Chiari, if the doctor tells you should not get a second opinion, walk out of that door and never come back. What should a patient do if they have a Chiari malformation? The doctor tells them this is a significant Chiari malformation. They have lots of symptoms, and the insurance company says no, which does happen occasionally. Often what they have to do is get a second opinion, which they might have to do anyway with their insurance company, and the doctor will write a justification for that surgery. And like the young girl we met yesterday, and the first thing the father said to me is, "Thank you for taking my child's case." And I was a little bewildered. Why should he be thanking me? Well, it turns out he told me he didn't have insurance, and it didn't matter to me. She's going to get the same care. We have a vast body of knowledge, but it's a field in evolution. We're learning more about it every day. We need to do much, much more research to help patients understand why they get it, what is the best treatment, and how to treat the after effects, such as the neurologic deficits and pain associated with this condition. It's going to take research, and it's going to take money to do this. And there are foundations out there, like the Chiari and Syringomyelia Foundation, that want to sponsor research, like the National Institutes of Health, like local foundations at university hospitals, or like the Congress of Neurological Surgeons, who has a Syringomyelia Fellowship, which pays for a young physician or neurosurgeon to study some aspect of Chiari and Syringomyelia with the hope to cure or at least alleviate the suffering that patients live with.